All right, we'll get going and expect that a few more folks will join us as we progress here. So welcome all. I am Lisa Jeckett, an investigator for LeaRRn's Didactic Core, and I'm pleased to introduce today's presentation for year 5 of our series, Using Health Systems Research to Revolutionize Rehabilitation Care. Please note that if you would like to enable closed captions for this webinar, there are 2 options in the Zoom navigation bar. You can either select Show Captions if it's visible, or if it's not visible, you can select More to access the closed caption feature and then select Captions. You can then choose your preferred language. Today's webinar follows our spring lineup of events focused on health equity and informatics. You can view these and our other archived presentations using the link in the chat. Opening our fall lineup of events on health equity and justice, our speaker today is clinical health psychologist, Dr. Anna Baumann. Dr. Baumann's research agenda focuses on the intersection of implementation science, adaptation science, and healthcare equity. She works to identify strategies that facilitate the implementation of evidence-based interventions in low-resource settings and historically underserved populations, both nationally and globally. Through this work, she has collaborated with several investigators in adapting and implementing evidence-based interventions in usual care, in different settings, and in different disease areas, including sickle cell disease, hypertension, mental health care, and cancer. Dr. Baumann's talk will be followed by a Q&A session. We ask that you please enter your questions in the Q&A feature of Zoom so that we can address them once the talk concludes. After the presentation, we will provide a link to an evaluation survey as well. And finally, we will wrap up our time today by sharing some upcoming LeaRRn events, as well as additional LeaRRn resources. And with that, I'm very pleased to introduce Dr. Baumann to present Enhancing Representation Strategies to Engage Diverse Participants in Research Activities. And Dr. Baumann, feel free to take it away.
Thank you. And hello, everyone. It's an honor to be here in year 5, and I've been in some of those webinars and always learning with you and with this network. So I hope that through the the questions and answers, we can co-learn and have a great conversation. So, see, there you go. I do want to disclose an important piece, which is the slides that I have right now were not audited for visual disabilities. So if you do need an audited slide, let me know, email me, and I'm happy to audit it and edit it for you. When I talk about equity and when I talk about representation, when I talk about diversity, it's important to me to share my positionality with you. In terms of demographics, I am a Latina, was born and raised in Brazil. Currently, I am dual citizen, able-bodied, white-skinned, colonizer, a mother, single mom in academia, cisgender scholar woman. And those markers I share with you because they permeate my lenses on how do I engage and talk about equity and representation in my own life and in my research. My own research is in the intersection between implementation, dissemination science, adaptation science, and healthcare equity. And so I say about this because my view is one of the many, many, many views around and perspectives around equity, healthcare equity, and representation. It's not the only view, and I want to recognize the multiple perspectives that are out there in the world. I also want to pause a little bit and recognize the challenges that we have right now in the global, in terms of wars, natural disasters, the feelings that we have. And to me, when we recognize those tensions and those feelings, it reminds me both the tension that we have, but also how thinking through equity, representation, diversity is then a more imperative. It's urgent, it's needed more than ever. So talking about this, right, in the context of this talk, let's define things and let's think through what is representation. So the title was Engaging Representation and Bringing Representation to Your Work. And when I think about those pieces, it's always important for me to really take a moment, sit down and think about what does that mean for you in your personal context? And what does that mean for you in terms of your work? Are those different? Are they similar? But most importantly, why do you think representation matter? What is the assumption that we're having when we think about we need to enhance representation, or we need to bring people in, right, diverse people in the clinical trials or in your healthcare setting? Why? I like to go and I like to define things, because when we define things, then we can have a common thread or conversation, right? So this is the definition in dictionary. Representation means people with different lived experiences, living conditions, different races, ethnicity, age, sex, sexual orientation. And NIH has those bullet points in terms of the definition of what they mean of representation and disparities. Racial and ethnic minority groups, people with different socioeconomic status, underserved rural communities, sexual and gender minority groups, people with disabilities was added last year. And so let's define and set a common ground across all of us. I personally struggle with the words representation and diversity, because sometimes we use them interchangeably. Sometimes some scholars have distinct definition for them. So I'm just going to offer some suggestions on how to really think through what might that mean for different people. And as you engage in your work and in your research, what I ask you is to really define what you mean by representation and diversity. So if you read the definition of representation, right, is it representing a group, a body? It can be from a historically marginalized group. What that means in my own head is that you might have a representation, say, of young adults in your study. It does not necessarily mean having diverse people in your own study. So diversity to me means having different people from different representations and different backgrounds. So I just want us to think through the words that we use and how are you defining them in your research, because those things matter, right? I asked you why representation matters and what is the assumption that you have in thinking about what is importance of bringing representation to your work. This is my assumption. My assumption is that by increasing representation and diversity in our studies, we'll have better understandings about interventions, the strategies to implement those interventions, and consequently, hopefully, we'll be closer to achieving healthcare equity. That's mine. I don't know about yours. Maybe your assumption is different. Your hypothesis is different, and I would love to hear about that. The important piece here is when I think about equity work and when I think about representation work, what we have been, several of us have been asking people to do is to make those assumptions explicit and to verbalize what it is that you're doing and why you're doing what you're doing. So I said equity. So let's define equity, because definitions are important, right? Inequality is what we have right now. Different settings, different people have different resources. Some of them have more than others. Equality then is when you provide the same resources for different settings. So you have the same stairs here for different settings and different populations. It helps some. It's not what is addressing inequality. Equity then is when you tailor the intervention, the recruitment strategies, the implementation strategies to different people, so then they get what they need at the moment that they need, at all times when they need. One day, I hope, in the field of healthcare, we can talk about justice. Justice is when you're dismantling the current systems that are in place that are affecting or permeating, right, and neglecting the care for those who actually need the most. And in this case, hopefully everyone can get their apples regardless of where they are. Again, definitions are important. So one way to define healthcare equity is the distribution of access and utilization of healthcare related services resulting in equitable healthcare outcomes and health status among members of a population, regardless of where they are, regardless of the variation. Everyone deserves to receive what they need at the moment that they need, at all times that they need. Equity then is everyone having a fair and just opportunity to be as healthy as possible. The catch, and this is why this is so hard to do, is that equity might not necessarily be just an outcome, but it's rather a process. It's an ever-going examination of the historical and contemporary injustice. And how can we then allocate the resources and the needs depending on the context that we have? So today, within the whole gamut of equity and healthcare equity, we're talking just about one piece, which is reach and engagement. It's one little piece, but it's one really important aspect of all of that. And I will go through 3 main points. So I'm going to go take a detour and talk about definitions and things. And I promise you, we're going to talk about reach. But I felt the need that we needed to take a detour so we can think about what does reach mean in the context of historically marginalized populations. Number one, for us to really reach and engage people, we need to recognize the historical context of the communities, including racism and discrimination. I'm going to bring 2 pieces of my own work just because I like the work that I do. And then we're going to work through for those pieces. In one of our papers, we talk about the guiding principles that we might have to think, or we could think when we think about healthcare equity. Let's go through them. 1, racism needs to be recognized as a fundamental driver of healthcare inequities. Racism means currently we have structures of oppression that affects the multiple levels, resources, and healthcare access. If we do not recognize those, we're not going to be able to reach those who really need us. Tons of paper have been talking about what racism is. And Kamara Jones and Lisa Bolek they say, unless we explicitly talk about things, we're not going to be able to address them. If we don't talk about them, we're never going to be able to address and measure them. So Kamara Jones says, we have to name it. We have to name the current systems in place that are affecting how we're reaching the people who need us the most. So the first reflection that we need to think through is, how is racism operating here? And how can we strategize to either decrease or affect or address racism in the work that we do? So here's a definition. What does racism mean? There are several different types of racism. One of them is the structural racism, which is the totality of ways in which society fosters racial discrimination via multiple systems, including housing, education, employment, earnings, benefits, credit, media, healthcare, criminal justice. The context by which affects how people interact, engage with healthcare system and their own health. Rachel Shelton, Prajakta Adsal, April O, and many others have been put forth recommendations on how to actively address racism in the context of implementation science, meaning in the context of how you implement interventions in usual care. We need to think through what are the theories that are informing how and why you're selecting the strategies or the interventions that you use. Are you doing multiple levels approaches? And how are you selecting the team that's collaborating with you in your own work? Guiding principle number 2. If we are to think about engaging diverse populations in our work, we need to think about actively engaging the voices of the community members. They are the ones who have the power and the privilege and the knowledge to tell us what it is that they need, want, or would like to have from us. We're going to talk about that in a little bit later. Guiding principles 3 and 4, meaning the hospitals are only one source of partnership and resources. How can we think about multi-sector partnerships in the work that we do? How can we conceptualize the context of the healthcare, including finances, political aspect, that influence the healthcare, the work that we do? So, with all of those principles, it leads to then, what does engaging the community and thinking through the history and the context of the community that we work with? Because the people that we are trying to engage, they are part of a community, and we need to understand the community. There are tons of papers and tons of ways of thinking about how to engage voices. But one of the things, if there's anything that you get out of this webinar, is the how we think about asking and engaging the people in our work. A lot of the things that I see in my own work, we do this deficit approach, right? Oh, the community does not have X. Oh, the people do not have X. So then come here and I will give you X. What a lot of scholars in the healthcare equity space are asking us to do is to have a strength approach. What does that mean? It means us going to the community and seeing in the eyes of what is actually working, what is out there. Asset mapping is a methodology that you can use, for example, to examine what is out there in the community and what is working already. This is an example of Gabi Boccini, who is doing beautiful work in asset mapping in the context of maternal health care. And in this paper, she shares about how her team went in and they did a windshield examination of the community. And look at the amount of things that are out there in the community just to support maternal health care. The catch was not that they didn't have assets. The catch was that the assets were not talking to each other. People didn't know what was happening in the community. So a big chunk of her own work is really to sit down with the community members and say, can we talk? And she's actually writing a paper now saying, I didn't need to develop an intervention. My intervention, all that it was to get people to collaborate with each other. Here's another way of putting asset mapping into a figure in terms of individual, community, institutional levels, to think through what are the strengths that we have that we can enhance, instead of always thinking about, oh, this community doesn't have, so I need to, do something else. Communities are resilient. People are resilient. How can we think about people in a strength approach? So with all of that, it follows the number 3. There's no hard to reach community. When you read hard to reach community, that's a lie. Because the problem is not on the community members, the problem is in how we are engaging the community members. The problem is in the historical perspectives of rightfully community members not having trust with the healthcare system. The problem is in us not being creative enough to think through how can we engage different voices. So let's go through there. This is a classic framework in the context of implementation science. And what I want to show here is that in the context of implementation science, we have an intervention, say a pill for headache. The strategies are, how do you implement those interventions? So say your provider knows how to prescribe this pill for people if they have the headache symptom, okay? The implementation outcomes are things like, is this intervention feasible? Can people actually do them? Is it cost effective? Is it sustainable? say that a pill in this case is feasible. Providers know how to do it. You've trained providers, life is good. The service outcomes in terms of patient centeredness, fine. But the problem is, if a person, it doesn't matter if you have all those things in place, you know what the intervention is, you know how to train providers in the healthcare system, and you know that it affects, the clinical outcome. But if a person doesn't feel safe coming to the hospital because he, she, or they might be deported, or a person cannot come to the hospital because he, she, or they might go to jail, or they cannot even get into the hospital because there's no ramp, what's the point of having effective interventions? So when we think about representation of our work, we really need to think about the context by which affects the lifestyle of the people that we want to engage. And that means focusing on the reach from the very beginning. Where are we doing our interventions? Who is absent from our work? Who is absent from our research teams? Who is absent from your own personal network? I would love to see more work in settings where people are going to. Schools, library, church, laundromats, food banks, parks, homeless shelters, correction facilities. Why do we need to wait for people to come to the hospitals at all the time? If, for example, our interventions are flexible enough that we can do it in different places. We're missing, if you take a look at any systematic reviews, we're missing voices of people like immigrants, refugees, homeless, non-binary gender, people with disabilities, children, elder providers. We are not engaging in representation and diversity in our clinical trials, which is crazy because we do have methodology on how to engage different voices. User-centered design, ethnographies, photo voice, collaborative engagement. Those are just some examples of the many, many, many examples that you can use to engage different voices. So, as you think about, how do I do this, Anna? What does that mean? There's no right or wrong way. The right way really is for you to think about what is the historical context in terms of repression of the people who you are thinking about engaging in your research. And then you can understand how to engage them. If people are afraid of coming to the healthcare system, you need to understand that. And then you need to address that. There are many ways you can engage community. Advisory boards are one, citizen panels. You can have them as a consultant, as part of the process in your research team, as crowdsourcing. There are tons of books about that. I love the work by Vera Sander Thompson and Melanie Goodman, because they talk about when community engagement comes in, when the community members come to your work, you really need to think about what is the value added of your work to the community. And so at the bottom there's actually a survey where you could sit down with your community members and have that clear conversation about why should they be involved in your study, period. I talked about, you need to understand your community and you need to ask them what it is that they want. This is a paper where people went in and they asked the community members, what would it entail and what would help you think through coming and being part of a clinical trial? 14 recommendations. This is a lot of work for us to do. What you will see in the first one is addressing concerns about research. Fear and issues of confidentiality are understandably valid, right? Provide information about the benefits of the research to people. Be transparent. When possible, hire research staff from the community. Think about different methods to engage in using information. Tailor the materials for the community. Offer compensation. And be prepared to think about legal aspects of the under or uninsured participants. Here's another set of conversation, another study, similar things. Think about if you're doing a trial around a healthcare issue, a health status issue, maybe participants are not coming because they are just sick. That's it, right? Think about the time constraints. Think about what the trial can have in terms of negative outcomes. It's like, I have to go travel, I have to park, I have to find childcare, I have to do all those things for your research. What benefits me? And then there is data showing that even if participants identify with the inclusion criteria, they might think that they're not appropriately benefiting for your trial, and they just don't engage with your trial. So it's really thinking about how can you sell what it is, the value added of people coming to your trial for them. Here are a couple, so I love this study because they tested different engagement strategies. So community recruiters, community partner referrals, clinical database, social media, participant referral, like the snowball sampling. In many studies, if you take a look and you really think through, the issue of trust could be potentially addressed through snowball and community members recruiting each other. The catch that we don't have in the literature are data like this, where you test the different recruitment strategies, including the number of referrals and the cost. We need more data like this. We need more quantitative aspects of what are the different strategies that work for different people for different trials. We don't have that. One way that you could get some of that and help with the literature are things like micro trials or studies within a trial, SWATs, where studies that you embed in a larger study. So say that you have your R1, you have your P50, you have your R34s, whatever big trial that you might have, you can pull out and do small trials within that larger trial. And you can do that to test different strategies and see, like the table that I just showed, which one works better for whom and how and why. So I'm not going to go through this, but I just wanted to show this is a SWAT trial of an R1, so a bigger trial, where for one site, what they did is they included a site visitation where they hang out with the site and they had a conversation, and you can see on the site intervention, the blue dot, that site intervention increase the recruitment rate. So sometimes you don't need a lot. But what we do need is to really think through what it is that we're doing and how we're recruiting people. And here are just some points for reflection for you. A thread in all of those slides is the relationship between us as researchers, us as clinicians, and the community. The best way to do that is to really think through what is the composition of your team, who is missing and why. And in that is to really think that if you have a diverse team, that does not necessarily mean that you're really listening to all the diverse voices. So you really need to think about within your team, how are you listening to each other? That's point one. Point two is the recruitment materials. We need to audit our materials. I am guilty of doing Excel file, clip art, here it is. But are your materials audited? Have you checked with the community members about the language, about the colors, about the figures? Who is recruiting where and how? And the where is not a trivial thing. If your hospital does not have a ramp, for example, for people with wheelchair, how are you recruiting them? So think about the place and the people in the process of recruitment. In that, my pet peeve recently is the demographic surveys. We, as all of us, need to be very careful about what kind of data we're asking in terms of demographic data. We might be having, recruiting, for example, gender diverse people. But if your demographic surveys are asking, are you female, male, binary outcomes, you're not going to be able to capture that data. So really think through your recruitment materials, your language. How does that affect people that are not cisgender, for example? And then think through your survey questions. Are you capturing intersectionality? Are you capturing things in platforms that are audited for visual disabilities, audited for literacy levels? Are you capturing all the social determinants of health? And it might not be the case, and that's okay, but then why? So engaging different people is not a one step, right? It's a multiple step in thinking about where you're doing, how you're doing, who you're doing, and then how you're capturing the data of who you are selecting, who are you engaging in your trials. The implication of all of this is that if your engagement process is not working, the problem is not on the community. The problem is on us, that we need to be more creative. We need to be more empathetic. We need to think through how we're going to meet the community where they are. And that's it. Thank you.